levels of care for our patients. Another case is diabetes. There's a lot of research showing now that a swab of blood from the gingival crevice gives us an accurate reading, just like a finger blood prick test, for diabetes screening. So this is, again, one research paper where they found that 50% of diabetes cases were undiagnosed until they reached critical levels. So again, stepping into a general health screening role is what we can start doing as dentists. Now, if we look at how we screen in routine recall appointments for our dental patients already, we already look for things like oral or mouth cancer. But the rates of that globally are about 1 in 325 people. So it's worth looking for. One of the topic du jour at the moment is people love looking for sleep disturbances as dentists for our dental patients. And again, it's worth looking for. About 1 in 4 of our patients may suffer from some kind of sleep disturbance, which will have oral presentation. So it's worth screening for. But when we look at how this relates to skin and skin cancer of patients that we see every day, globally, rates are about 2 in 3 patients before the age of 75 will develop some form of skin cancer. You know, that's particularly prevalent where I am in Australia, but it is a global statistic. So this is really what we're talking about. Although I'm about to start to talk to you about cosmetics and aesthetics on the outside of the mouth and on the face, fundamentally, we are all health practitioners. So everything we do has to have a platform of health first, and then an aesthetic benefit. Really, where we go wrong with our patients and what we have to remember is that while we may be after an aesthetic outcome, we can't reach that unless everything is healthy first. So these are some classic examples of patients that came to see us that had developed skin cancer that they hadn't had picked up by a dermatologist or a general practitioner. And we were able to take photos of this, track it over the 4 to 6 month recall, and refer them off to a treating skin cancer specialist. The picture on the left there was some basal cell carcinomas on the patient's forehead that we found just by seeing that that doesn't look healthy in the dental chair. And then the little red spot on the right picture is a squamous cell carcinoma on the angle of the mandible. So again, we're not diagnosing and treatment planning and treating skin cancer here, that it doesn't take much for us to step up and say, look, that doesn't look good, let's refer you off. So essentially what I'm encouraging you to do here before we even get onto the aesthetic component is remembering that you're a health practitioner, remembering that you're in a unique position to start to offer your patients a higher level of care across the head and neck area. So we don't just want to focus on the teeth and gums anymore and how great they look, we need to focus on the full head and neck area. So how does this flow into the aesthetics conversation? So I'm hoping most of you are sitting there and saying, that sounds very reasonable. That sounds like something we should be doing as dentists, and it's not at all controversial. So for me, just talking about aesthetics doesn't make that conversation automatically controversial. You know, if we're meant to be looking at the entire head and neck area as health practitioners, why wouldn't we also look at the entire head and neck area from an aesthetic point of view? So we know that from a macro level, to be able to get the results that you're seeing on your screen, where we're taking someone who looks a bit stressed and run down and their skin is deteriorated, to make them look aesthetically better, we have to primarily focus on improving the health and quality of their skin. So just like inside the mouth, if you wanted to make the teeth look better, fundamentally, you have to make them healthy first. The same applies to the extraoral tissues. So the transition here between therapeutics and aesthetics is quite clear. We can't make someone's skin or teeth or gums look better if we don't first focus on making them healthier. So the conversation about should dentists be entering the sphere of Botox and extraoral cosmetics really fundamentally is not controversial because we already should be doing it from a therapeutics point of view. In our organization, we just have a catch cry that it really doesn't stop with teeth because, and neither should dentists, it doesn't really matter how great you make the teeth look. If the face still looks bad, it's just going to look bad with a good looking set of teeth. So to get the real great aesthetic results for the overall head and neck area, we have to be considering the patient as a whole. And a lot of people, and certainly dentists, when I show them this picture, focus right in on that big horrible amalgam that's sitting on that 1/6 up on the top right there. But we want you to take a step back and look at the patient as a whole, because that's what they see. And this is what their friends and family see. You know, a smile is a full face event. It extends up through the entire facial musculature throughout all the different layers of tissue. It causes tension around the nose, through the midface, up around the eye. And this is what we have to take into account when we consider ourselves aesthetic dentists or cosmetic dentists. If we're going to improve someone's smile, we can't stop at teeth and gums. We have to go as far as the smile goes. And that means it's a full face event. And that means to get the best results, we need to be focusing on addressing all the issues throughout the whole face and offering layers of treatment to counter all of those issues. Now, this is actually a marketing brochure from a very popular digital smile design company around the world. I won't tell you which one, you can probably guess. And this is their marketing brochure. This is them saying, this is the best dentistry we can do. Now, for me, this is a complete failure because, again, I don't do work on teeth, but I'm assuming the teeth here are straighter, stronger, and healthier. Great job on the teeth. But what I can't get over is that the rest of the skin, the rest of the tissues of the head and neck area are so unhealthy. The area I've circled in red there is borderline precancerous. Even if you look at the lips, I can't even see where the lip border is anymore, where the vermilion border, where pink meets white is completely obliterated because of how unhealthy the tissues are. Now, if you look at the shade of the teeth in this marketing brochure, it's very natural. It's been made to look very natural. So they've compromised on the shade of the teeth to fit in with how unhealthy the rest of the tissues are. Why wouldn't we just make the rest of the tissues nice and healthy and improve the aesthetics of the rest of the face and then be able to make the shade of the teeth lighter? So what I'm telling you here is that there is an interplay between the health and aesthetics on the outside of the mouth and the health and aesthetics on the inside of the mouth. The two are not separate as they've traditionally been treated. Dentists treat teeth and gums and somebody else might treat the rest of the face. To get the best results now as an aesthetic dentist, we have to be blending all of the treatments and all of the different tissues together. So to be a really great aesthetic dentist now, it's almost a non-negotiable that you have to at least know how to work with lips and as well as teeth and gums, and certainly work throughout the rest of the face. This is another marketing brochure from the same kind of digital smile design company. And this is the end result, them saying, look, this is how great our dentistry could be. This one actually makes me sad because you look at that end result and again, great job on improving the teeth, but they've left that patient with a huge gummy smile. I'm going to show you a treatment very shortly where you could give a very quick and easy injection of botulinum toxin or Botox either side of the nose. And within 2 seconds at the end of that insert appointment, that top lip would have dropped, you cover up the gingival display and the whole aesthetics of the smile looks better. But again, going back to what I just said, a smile doesn't just confine itself to the lips and the mouth, it's a full face event. So if we drop the top lip, it softens the depth of the nasolabial, it softens the muscle tension around the eye and the midface, and everything looks a lot softer and much more aesthetically pleasing. So as I just said, really to be a great aesthetic dentist now, you have to be considering more than just teeth and gums. You have to be considering all of these different components of the head and neck complex. That's really why all of the founding fathers of dentistry in university got us to really understand head and neck anatomy.